Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And my topic for today is when the patient is mistaken. I'm going to talk about some common conditions that patients are mistaken about and normal things which patients sometimes think are signs of disease. There's a thunderstorm in my area, so if you hear any loud noises, it's the thunderstorm. As usual, everything I say reflects my own opinions based on my own experience and study, and not the opinions of the Social Security Administration or any other medical body. Now, the first condition patients have often been worried about for a long time is they were told by their parents they had a heart murmur in infancy. And people often go through life thinking they're sick or they have a defective heart. Here's the truth. Most newborn babies have a heart murmur. It's because their hearts beat faster and harder than the hearts of older children and adults. It's called a functional or flow murmur. There are some newborn babies who do have heart disease, some of it quite serious and requiring surgery, but their murmurs are usually very different from the normal functional or flow murmur, and they tend to have other problems, such as being blue due to lack of oxygen in their blood, or having trouble with feeding, or difficulty with breathing. So if your mom told you that when you were born you had a heart murmur, but all your life you've had no heart problems such as chest pain, excessive shortness of breath, or fainting spells, then you can stop worrying about it. The next problem is really a problem of communication between the doctor and the patient. I can't count the number of patients who've responded positively to the question, do you have double vision? However, when I ask in detail, it turns out their vision is blurred. There is a world of difference between blurry or out of focus vision and double vision. Double vision is when you look at one thing and see two. It can be horizontal, vertical, or skewed. Double vision indicates serious disease until proven otherwise, and almost always requires specialist consultation. Here's an example from my own experience. My best childhood friend developed double vision when he was 20. He went to the emergency room and was told that it was his nerves. However, the double vision persisted. He went to another emergency room. The doctor there couldn't figure out what was wrong, but did the appropriate thing and referred my friend to an eye specialist. The eye specialist realized something was seriously wrong and ordered a CT scan of my friend's brain, which showed a cancer, a malignant pinealoma, a form of brain cancer that was pressing on the nerves that went from the eyes to the brain. Luckily, my friend's cancer was cured with radiation therapy. The next thing that patients complain of that is often, but not always, normal is dropping things. There is not a person alive on this earth who hasn't at one time or other dropped things. Dropping things can be normal or it can indicate disease. If it's due to disease, one or more of these factors should be present. Either weakness of the hand or poor coordination of the hand. Often people who've had strokes have normal grip strength, but they can't coordinate their movements. Or loss of feeling in the hand, or pain with hand movement, as seen in arthritis. If none of those factors are present, the dropping things is likely normal. The next thing that's often normal is fatigue. Again, there's no person alive who hasn't felt fatigued or tired some of the time. Fatigue can be due to physical or emotional problems. Depressed people tend to feel tired and having no energy all the time. What is significant is if the patient becomes fatigued, weak, and tired after activities that a normal person would not become fatigued while doing, such as someone who feels exhausted after climbing one flight of stairs or walking one block. That's a serious fatigue that a doctor needs to investigate. The next complaint that often reflects no disease is complaints about cognition and memory. I always shrink a little inside when a patient tells me they have impaired cognition, because in my 43 years of medicine, I've only examined one patient who told me that, and I felt they really did have trouble thinking. If somebody can think well enough to talk about their impaired cognition, their thinking probably is pretty normal. Same thing with memory. Everybody forgets from time to time. Lethalogica is the phenomenon of having a word on the tip of your tongue, but it just won't pop into your head. It often does pop into your head when you stop talking or change the subject, and that's completely normal. Patients who have serious problems with thinking and/or memory usually don't volunteer that information. It's usually family members or friends who tell the doctor, and often the patient will insist that there's nothing wrong with them. I know a psychologist who does a lot of mental competency exams. He examines patients to determine if they're competent to make decisions about their finances and other aspects of their life. And he told me that people who come to him complaining of problems with their thinking and memory have normal thinking and memory but are depressed. People who actually have problems with their thinking and memory are dragged in by a family member, the patient saying loudly that there's nothing wrong with me, I don't know why I'm here. I have a simple memory test I do with most patients who are complaining of impaired memory, which is I give them 3 words to remember and see how many they remember at 5 minutes. I give them the 3 words, I ask them to repeat them, and then I ask them to repeat them again, and then I set my phone timer for 5 minutes. If they remember all 3, that's a good indication their memory is intact. 2 out of 3 is questionable. 1 out of 3, they definitely have a memory problem, and 0 out of 3, they have a really significant memory problem. I did a Social Security disability exam on one poor man who couldn't even remember one of the words as soon as I'd told them to him. I repeated them 3 times, and each time he could not remember them the second I stopped. Now, he had a significant memory problem and was significantly disabled. If he took a new job, he'd immediately forget the instructions on how to perform that job. I've already talked about how little information about a patient's clinical status a doctor obtains from their MRI report. But here's another spinal finding that is normal. During my exam, I asked the patient to show me their neck range of motion by having them move their head around in as big a circle as possible. Almost everyone who does this exclaims to me that their neck pops and cracks when they do that and asks me if I heard it. The answer is no, I did not hear it. Only you can hear the noise your neck makes, and also neck popping and cracking with movement is completely 100% normal and does not indicate neck arthritis or any other neck problem. Next, I'm going to talk about arthritis. I commonly have patients who tell me they have rheumatoid arthritis, and most of them do not. The most common type of arthritis in adults is osteoarthritis. That's the type of arthritis everyone gets from wear and tear as we age. Rheumatoid arthritis is a rarer condition, almost always in women. It's very rare to have men with rheumatoid arthritis. Osteoarthritis is about evenly distributed between women and men, and rheumatoid arthritis often is much more severe and disabling than osteoarthritis. The key is in the hands because both rheumatoid and osteoarthritis show up in the hands. In osteoarthritis, what we call the DIP and PIP joints of the fingers are affected, and they form bone spurs, which results in the joints becoming bigger or swollen. However, the swelling is due to enlargement of the bone. So if you feel the swollen joints, they feel hard, like bone. In rheumatoid arthritis, the MCP joint of the fingers, this joint here, is the most common joint affected. And there is what we call synovial hypertrophy, which is the soft tissue around the joint swells up and becomes thickened. And it feels soft or squishy, like dough, unlike the hard swelling of osteoarthritis. So if the patient has swelling here, and it's hard, and this is pretty normal, they have osteoarthritis. If the patient has swelling here, and it's soft and squishy, they likely have rheumatoid arthritis. And you can see this in yourself. The final condition patients are often mistaken about is headaches. A lot of disability patients tell me they have migraine headaches, but they really don't. They have tension headaches. So I'm going to talk about the differences between the two common types of headaches, and you'll be able to determine for yourself if you have migraines or not. Tension headaches are nearly ubiquitous and are basically considered normal. Everyone gets tension headaches from time to time. They are typically described as being mild to moderate in intensity, although I don't think that's very helpful because patients' pain tolerances vary so widely. I've seen a patient walk on a broken leg, and I've seen a patient rush to the emergency room for a 1/4-inch paper cut on the tip of their finger. So take the patient's report of headache intensity with a grain of salt. Tension headaches are bilateral, which means the patient feels them on both sides of their head. They often feel them like a band tightening around the head. They do not throb with the heartbeat. There may be tenderness of the head or scalp, which is not present in migraine headaches. And the headaches may last from half an hour to a whole week, or the patient may get them every day for weeks or months or years at a time. Migraine headaches are different, and there are two types of migraine: simple migraine and classical migraine, also known as migraine with aura. And aura only occurs in some people with migraine headaches, never in people with tension headaches. And aura is a neurological symptom that lasts for about 30 to 60 minutes, and then as it fades away, the headache begins. The most common auras are visual, and the most common visual aura is a sort of curtain or wavy lines on one side of the patient. This is a visual hallucination. However, auras can involve any part of the nervous system. They may cause numbness, they may cause weakness, they may even cause abnormal smells. I had one patient with no history of migraine who came to the emergency department because they'd suddenly become completely blind in one eye. as we were working up the patient and doing the various necessary tests, the vision came back and they developed a severe headache, which was bad but good. The bad was they had a severe headache, but the good was we now knew that the cause of their blindness was, first of all, not permanent, and second of all, not serious. Auras occur in a minority of people with migraine, but if you have an aura before your headache, you have a migraine, period, because no other type of headache causes an aura. Migraines can last between about 4 hours to 3 days. However, they're never brief, like 30 to 60 minutes, and they never occur day after day, week after week, month after month, year after year, except in an extremely rare condition called status migrainosus, where a migraine may be present for weeks or months. However, even in status migrainosus, the headache always goes away at times. 3 things may make a migraine worse: bright lights, which is called photophobia, loud noises, which is called phonophobia, and normal activities such as walking or climbing the stairs. Migraine headaches are often, but not always, associated with nausea and vomiting, which may be severe. I saw a patient about 30 years ago, a lab technician in the hospital where I worked, who never complained of anything, got a severe migraine and was lying on the stretcher in the emergency room with the lights out, drenched in sweat and vomiting repeatedly. And because of this, Social Security can grant disability for migraine headaches if severe and frequent enough. The final thing that differentiates migraine from tension headaches is response to medication. There are a group of drugs called triptans, the first of which was sumatriptan, brand name Imitrex, which, if taken early on during the headache, usually relieve migraines, but have no effect whatsoever on tension headaches. So if you've had a headache that's fairly severe, and if you know that if you take a triptan, as soon as you feel it coming on and it goes away, usually within about 15 to 30 minutes, then you have a real migraine headache. Not all migraines are relieved by triptans, and the longer you wait between the onset of the headache and when you take the triptan, the less effective the triptan is likely to be. So this isn't an absolute differentiator between migraine and tension headache. Well, those are the most common areas where I see patients mistaken, and I hope it's been helpful. And as always, remember, if it happens, it's possible.